Good morning, everyone.
Good morning.
I'm Kiki Norwood. We have Kayla Williams and Seth Perry. And today we're going to be talking to you about ankylosing spondylitis. Alright, today we will define AS and its pathophysiology, identify the typical clinical manifestations and associated functional limitations of AS, explain the diagnostic tests and differentiate AS from other conditions with similar symptoms, outline the rehabilitation process, and discuss physical therapy interventions for AS patients, and summarize expected outcomes of treatment and the role of ongoing management.
What is ankylosing spondylitis? Referred to as bamboo spine and Marie Strumfeld disease. It is a chronic inflammatory disease, and it primarily affects the spine and the sacroiliac joints. It typically begins between 15 to 40 years of age, and it affects men more than it does women. It is associated with the HLA-B27 genetic marker. HLA just stands for human leukocyte antigen, and it's a systematic condition that can affect other joints and tissues such as the hips and shoulders. It can cause pain within those areas, and the eyes by causing inflammation of the middle layer, and the heart by increasing the risk for ischemic heart disease.
Alright, so there is no real known cause to this disease. It is an autoimmune disease, so it can be triggered by environmental or bacterial factors. It does have that correlation with HLA-B27, but that is not a determining factor. Just because you have the HLA-B27 does not mean that you have AS. Just because you have AS does not mean that you're going to have the HLA-B27.
Some clinical manifestations. Some signs are flattening of the lumbar lordosis, kyphosis of the thoracic spine, and hyperextension of the cervical spine. Some symptoms are back pain at night, back pain and stiffness between 2 and 5 a.m., which most time patients will try to get up and move around because movement improves the stiffness, and backache during the day, which is intermittent. And then functional limitations include impaired activities of daily living, such as bending, twisting, and sitting for prolonged periods, reduced respiratory capacity. The costovertebral joint involvement restricts lung disease, and mobility limitations include walking, climbing stairs, and maintaining an active lifestyle. Some tests and measures includes imaging tests such as X-ray, MRIs, and CT scans. Laboratory tests such as genetic and or elevated inflammatory markers. Functional tests include the Schobert's test, which is basically the clinician will mark 10 centimeters above the L5 vertebrae and 5 centimeters below the L5 vertebrae along that midline, and they will have their patient forward flex maximally, and they will measure the distance from the upright to the forward flex position, and patients with normal spine mobility should have an increase of 5 centimeters, so therefore it should be greater than 20 centimeters overall. Also the bad ankylosing spondylitis disease activity index, which is a tool used to assess disease activity in patients with AS. Bad ankylosing spondylitis functional index, which is a set of 10 questions designed to determine the degree of functional limitations in patients with AS. Range of motion testing, of course, and the chest expansion test, which is performed with the patient's hands elevated and folded behind the head. The clinician takes a circumferential measurement of the patient's chest at the level of the fourth intercostal space and just below the breast in females. The chest circumference is measured after a maximal force expiration and again after a maximal inspiration. The expansion should be more than 5 centimeters. Expansion of less than 2.5 centimeters is considered abnormal.
So, excuse me. So for differential diagnosis, this is going to present as, like we said, an autoimmune disease. So it shows up a lot like rheumatoid arthritis. But one of the main differences between this and RA is that this is going to affect larger joints, and it's not going to move as distal as RA would. So it typically affects the hands and the feet first for RA, and it's less likely to involve the spine. With exception for severe cases, RA will move to the cervical spine, which even still is some of the smaller joints of the spine. and it has no specific association with the genetic marker that we previously mentioned. And then another similarity that it has with psoriatic arthritis, this involves the skin, so the psoriasis will change the skin texture at your hands and your nails as well, and it'll give you the what's described as sausage digits, so it'll swell your fingers. So the identifying markers, again, between rheumatoid arthritis and psoriatic arthritis is that it's going to move further down towards your hands and feet. And then it's also, of course, very similar to mechanical low back pain, like a lot of the other abnormalities and pathologies that we're talking about. But this pain is typically positional, and it's aggravated by activity, and it's not as systemic as this pathology is. So for the rehabilitation process, unfortunately, because this is the autoimmune disorder, it's not as much a cure. You're gonna find activities that will reduce symptoms, but you're not ever gonna reach a point to where they're completely fixed of this ailment. So for the maximum protection phase, your main goals are to reduce inflammation and pain and maintain that range of motion. So of course you want to do gentle range of motion exercises for the spine and any peripheral joints that are affected by it. Isometric strengthening training to maintain the muscle activity around the inflamed joints. That way you're not losing any strength over time. And then just the pain management strategies for like modalities, which is typically the heat and ice TENS, but a lot of NSAIDs as well. And then for the moderate protection phase, you want to maybe even possibly like work on the mobility and the posture to prevent deformities, because that's one of the biggest issues with this pathology is that people become sedentary because of the pain, and it causes the disease develop further and cause more issues. So you also want to do strengthening of the spinal extensors and abdominal muscles so that you can maintain that postural control, and then thoracic expansion exercises to improve the breathing capacity, which is why that chest expansion test was so important, because this is one of the main symptoms of this is that you'll have that depressed breathing rate. And then for the minimum protection phase, you want to try to maximize function and prevent the disability. So this is kind of like long term, so people will kind of stay in that moderate to minimum protection phase for the foreseeable future, just because it's going to be a constant battle to keep their posture and keep their mobility. So maintenance of postural exercises and strength and stretching, continued aerobic conditioning and functional training for balance, coordination to improve mobility and independence. And then, like I said, the education on long-term self-management and activity modification, because of course, if they're still doing things in their daily activities that are causing more issues, they're gonna wanna adapt to that, because they're not gonna be able to do that forever. And then for the likely outcomes, like we mentioned, we're keeping them at a high level of function, the highest level of function that we can maintain with reasonable exercises, and we wanna slow the disease progression. So therapy can help manage the pain with those modalities that we talked about and improve the quality of life. Without intervention, it can cause severe postural defects and completely change the way that they're supposed to get around in life, or even take away their ability to complete tasks altogether. So just as far as for prognosis, you can see significant symptom reduction for a few weeks or in the first few weeks to months, but it will never fully mitigate, and you're just gonna have to learn to live with the deficits, but also work with them as best you can for the foreseeable future.
So, for an overview, AS is an inflammatory disease that often occurs in men ages 15-40. There's no real known cause, however, it has been linked to HLA-B27. The patient may complain of back pain at night and have trouble bending, twisting, climbing stairs, etc. It's normally diagnosed by imaging and functional tests, however, they can have a diagnosis from a rheumatologist. Rehabilitation goals focus on decreasing pain, inflammation, improving mobility, and maximizing function. And the patients are expected to have a reduction of symptoms within weeks to months. If it is left untreated, the disease can lead to postural deformities and disabilities. These are our references. Any questions?
Good job. Go back to your rehabilitation process. So notice most of you all, for your rehabilitation process, most of you all are being general or broad. So it's not specific. Your questions are gonna be specific. So now you're gonna have to extrapolate, and you're gonna have to know what's going on with the condition. This is where you could trip, okay? But I'm helping you with that so that it doesn't happen. Okay. So I chose someone on this side the last time. So on that side over there, I'm gonna choose Poojan. So Poojan, you come up and read it if you have to. You need to come up and see it. So it reads, which of the following interventions should the PT include in the plan of care for a patient diagnosed with ankylosing spondylitis during the moderate protection phase? Now you gotta know how the person's gonna likely present with ankylosing spondylitis.
Probably chest press.
Okay, Poojan said chest press. All right. I'm gonna put a star by that as the answer Poojan chose. All right, who all agrees with Poojan with chest press being the best answer? If you agree with Poojan, raise your hand. Poojan, nobody agrees with you right now. So go ahead and explain to them why you chose that.
For chest expansion. So whenever you go down, you get the chest expansion.
Okay, I can buy that, but it says chest press. So I'm gonna say, I'm gonna make this answer choice better. And I'm gonna add supine chest press. So the person lying supine on a treatment table. Thank you, Poojan. Okay, now, would you still keep C as the best answer? Probably not.
You're strengthening more so when you're supine.
Okay.
So you're shortening the pectoral muscles,
Mm-hmm.
which is now expanding the chest or the chest.
Okay, so you're gonna erase that? You're gonna erase that as your best answer? All right. So he provided his rationale for why he changed that. Anybody on board with Poojan with that? Raise your hand if you agree with him on that, why he changed it. Okay, you got some agreement on that one. So, all right, no opposition, so keep it going. So you're gonna rule this one out? So he's gonna rule that one out.
You want to push up as well?
He ruling out push-up. Oh, test taking. Getting better, test taking. So did you rule out push-ups for the same reason you ruled out C?
Yeah.
Okay. Now you're between A and B. You're gonna go with B. Why?
You're up here, expanding your chest.
Okay. So chest expansion with D2. All right. I can buy that. All right. And so you're gonna rule out A?
Yes.
Okay. So now you gotta know why you're ruling out A as well. Okay. So where's your rationale for ruling out A?
So when you're going back this way, you're doing with the chest press and the push-ups.
Okay,
Shortening.
okay, all right, shortening the pectoralis, major and minor muscles. All right, I can buy that. So, good job, Gujan. So, up extremity PNF D2 pattern, active range of motion with a 5-pound dumbbell is gonna be appropriate in your moderate protection phase for the condition and likely presentation of ankylosing spondylitis. Does that make sense? So now, go back to your rehab. So this is what I want to get y'all to understand. Look in the moderate protection phase. I'm teaching you incorporating some test taking strategies in my instruction. So see how it says postural correction exercises? That is broad. You see your answer choices? Those are specific. Okay? So y'all are going to be studying, you all may be studying this, but then you may get to the test question and you could freak out because if you don't know what you could specifically do for postural correction exercises, then that's where things can take a left turn. So now when you look at your classmates' presentations and you see these broad interventions, now you gotta go to your therapeutic exercise book and see what can I actually do for this condition for this general or broad intervention. So postural correction exercise, general broad intervention, non-specific. Now you gotta go to your book and see what you can do specifically. Does that make sense? Because your answer choices on your National Physical Therapy exam and on my exams, your answer choices are going to be specific interventions, okay? And that's how it's going to be on your National Physical Therapy exam. Now you got to know what category these interventions fall into, and you got to know which phase of the rehab in which to use these interventions. Does that make sense? All right, good job. Okay.